All right. So a little bit of review on ankle and lower leg pathologies, obviously. So, right, guys, as you know, go ahead and, there we go. All right, so clearly, right, we're talking about the ankle. We know the anatomy already, right? We know the ankle is made up of the tibia, fibula, talus, and calcaneus, right? And that the joint, right, that is made up between the tibia and the calcaneus, is known as the talocrural joint, okay? And the space, right, between the talus and the tibia on x-ray is referred to as the ankle mortise. We're going to see pictures of that in a second. Sorry. Okay, so ankle ligaments, obviously. Laterally, we've got the ATF, right? And what surface, and just as a matter of review, what surface anatomy do we have and see that tells us where the ATF lies? What's the name of that surface anatomy? What's it called?
Sinus tarsi.
Sinus tarsi. Bingo. Okay. Obviously, we have the calcaneal fibular ligament as well, the CF, right? And then the PTF. What is the best way to palpate the PTF?
And then dorsiflexion,
Okay.
evert or invert.
Yep. So full dorsiflexion, right? Where do your hands go? Where do your hands go? And this is just palpation. Remember, just drop that finger right back behind the lateral malleolus, and you'll run right into the PTF. Okay. So syndesmosis, obviously, right? Oh, what was that, Bennett? Nothing.
Nothing.
Okay. All right. So the syndesmosis, obviously, we have the anterior tibiofibular ligament, and there is the posterior tibiofibular ligament as well, but that is obscured, obviously, by the soleus and the Achilles tendon. It's not directly palpable. There are also other stabilizing ligaments that we'll see in a second that run, that run between the tibia and calcaneus and other structures as well. Okay, so here we go, guys. A little bit of review here anatomically, right? This is ankle cadaver anatomy here. Okay, so obviously, okay, what first and foremost, all right, I'm gonna get my little tool out here. Who can tell me, this is what view of the ankle is this, by the way? What aspect of the ankle am I looking at in this picture?
Medial.
Okay. All right. Okay. Charlie, why do you say lateral?
I have no idea.
Okay, so I know that this picture, right, is kind of confusing, but look right here. Okay, here's the interosseous membrane. Okay, there's the anterior tibiofibular ligament. Here's the tibia, this big bone over here. You see the fibula, long skinny bone right over here. Lateral mal. Okay, there it is. All right, so my question for you, what ligament lives right there? What is that? Look at where it runs.
The ATF.
Yeah, it's the ATF. Fantastic job. Okay, nice. All right, what ligament is this? What ligament's in that circle right there?
Yes.
Yeah, Izzy. Nice job. Okay. And then obviously we can't see the PTF, but it's back here behind the lateral malleolus. Okay. Obviously we have the talus here. Okay. Really interesting. So here we have, okay, this number is 16 down here, right? These guys, what tendons live over here that attach on the base of the fifth? Who can tell me?
Brevis.
Yep. Okay, what's another name for that?
Peroneus.
Yep, Peroni's brevis. Fantastic job. Okay, so obviously, right, when we're looking at an ankle, right, all of these structures are things that we need to be able to palpate. Okay, so fantastic work. Okay, now obviously, right, we obviously cannot neglect the deltoid or the syndesmosis either, right? Those are obviously also very important. All right, let me erase my drawings here and we'll go to the next slide. Does that make sense, guys? Kind of with the way that, I mean, you guys can definitely see these ligaments pretty clearly, right? I wanted to find a good bit for you guys to show you these things in real life. All right. Okay, here's the deal. Check this out, okay? So ultimately, we remember and we know what our special tests are, right, for the ankle, right? The ATF, if we're looking at an ATF sprain, we want to look, look at the anterior drawer, perform that test. Okay, Taylor tilt, which we've done in class, ATF, CF, and PTF, right? And if we remember correctly, right, all that has to do, okay, is with essentially the ankylation of the foot. So if I want to do Taylor tilt for the ATF, what position, how do I perform that?
Plantar flexion,
Yeah. Okay. What about just for the CF?
neutral,
Bingo. Okay. PTF.
full dorsiflexion.
Yep. Okay. Cool. Very nice. Okay. Now, so obviously we use the Taylor tilt, and that can also be done medially to check for the deltoid. And then obviously we use Klager's for the syndesmosis. Okay, to check syndesmosis integrity. What's another test that we can also use? You guys remember the squeeze test? You guys remember seeing us do that? What did we do for the squeeze test?
Squeeze the tibia and fibula together.
Yep. And what am I looking for?
Pain at the syndesmosis.
Bingo.
Relieve
Okay.
the pain, you squeeze it, and then it goes back.
Okay, very good. All right. Here's the deal. I want to show you guys this because this is actually super important. Okay, I'm going to teach you guys a couple of, actually, I'm sorry, I went way ahead of myself. I apologize, you guys. Okay, what you guys are seeing in front of you on this slide is a stress x-ray. Okay, these are actually stress x-rays performed to the ankle. We know that because obviously this individual, either physician or rad tech that's doing this x-ray is wearing lead gloves, right? So anyway, I mean, you can see the Taylor tilt here applied, particularly in the presence of, like a lateral ankle sprain, right? And you can see how much of a gap we have, right, between the talus and the tibia here. I mean, pretty incredible, right? Conversely, we come over to the picture on the far right. Obviously, he actually releases kind of that Taylor tilt, and everything goes, pretty much back to neutral. However, what you can see on this X-ray is a little bit of widening of the medial clear space at the talocrural joint. Don't worry about that word. I'm going to explain that. Okay, I'm going to explain exactly what I mean. Okay. So what in the world? Okay, what about these what are we talking about with these X-rays? Okay, here's what I want you guys to know. All right. Now, if you take a look at the picture on the left, anytime you look at a normal ankle X-ray, all right, you're going to have a couple of things that you need to look at, particularly at the tibia and the fibula. All right. First and foremost, a patient should have, tibiofibular clear space, right, which essentially is the gap or the black line between the bones. Okay, that should always be less than 5 millimeters. Okay, and you can see this other interval here with the blue line. Okay, this is known as tibiofibular overlap. So on an X-ray, the tibia will actually look like it's almost kind of like laying underneath. Technically, it is. It'll look like it's laying underneath the fibula, and it's kind of overlapping the fibula. Okay, so tibiofibular overlap here, right, should be 10 millimeters or more. Okay, now if we look at, and I'm going to do a little bit of drawing here, right, we look at the clear space, okay, between the talus, basically at the ankle mortise here, all right, Whoops, it's a badly drawn arrow. Okay, clear space at the talocrural joint should not exceed 4 millimeters. It should always be 4 millimeters or less. Okay, so sorry, my dog's being ridiculous. Sitting over here whining. Child. But if you look at that X-ray, right? If you look at that X-ray, right, on the right-hand side, okay, what's the one thing that you notice based on these two rules that we have over here with interpreting? What's the one thing that you don't see, okay, on this picture on the right, as opposed to the left? What is actually completely gone?
We can't hear you.
Okay, sorry. So if you look at this X-ray, if you look at this X-ray on the right, okay, can you guys hear me now?
Yeah.
Yeah.
Okay, sorry. What do you notice, Kate? What do you notice about this X-ray on the right-hand side as opposed to what we see as far as these rules on the left? Okay, what's not present in this X-ray?
There's not a gap between the tibia and the talus. Like,
Okay,
it's
yeah.
close together.
Okay, and what else do we notice here? Izzy, you're absolutely right. What else do we notice here?
There's no tubular overlap.
There's no overlap. Okay, now check this out. Okay, we know already that the clear space at the mortise should be less than 4 millimeters. Okay, and we look at this over here on the medial side. Look how widened that is. You guys see it? That's hella widened. It's very, very widened, right? And so what type of injury do we think this person has just by looking at the spacing? What type of sprain? Did you say medial?
I mumbled it.
What?
Yeah, so medial.
Not sure.
Okay, so yeah, this guy has obviously disrupted his deltoid complex. Okay, how do we know that? Because here's the tibia. All right, here's the talus. We have a really widened interval here between the tibia and the talus. Okay, now remember what we said. Okay, generally speaking, if the deltoid completely fails, what's the next joint that will likely fail after that? With an inversion sprain or with an eversion sprain, I'm sorry. Remember what we said?
Syndesmosis.
Bingo. The syndesmosis will fail next. Okay, and we see that that's happened here because we've completely and totally lost tibiofibular overlap, right? And we have a widened interval, right? Does that make sense to everyone? Yeah. Okay. If I'm like, Wade, you need to slow your roll and explain that, I will do that. We're good.
Good.
All right. Cool. Okay, so remember, guys, we talked about the Ottawa ankle rules, okay? And the question we were asking when we talked about the Ottawa ankle rules is first and foremost, right? Does this patient need an X-ray? Yes or no, right? And so who remembers, right? And it's obviously here on the screen for you as well, but who remembers what are those bony zones that we need to be palpating and checking for if we're ruling out, if we're trying to decide, excuse me, if we're trying to decide whether or not someone needs that. Who remembers what they are?
Can they walk? Are you talking about what are the rules?
What are the rules? And so by asking the question, what are the rules? Tell me what the zones are and how the rules impact those zones.
Are they tender?
On the posterior side of either malleolus, so that's 2 rows.
Yep.
I think. But,
Yep.
Base of the fifth,
can they walk more than 4 steps?
Yep. What else?
navicular.
Navicular, bingo. Okay. All right. Now, if you guys remember, right, and there's a reason why we brought this out. Why use these rules in the first place with ankle sprains? Who cares? Like, why are these important? What do we know about the anatomy that makes these rules relevant?
It's very common to fracture the base of your fifth, or like Jones fractures.
Yeah, Izzy gets a gold star. Fantastic. Yes. Okay. All right. Way to go, Izzy. All right. And then obviously, posterior tenderness, we need to obviously look out for fractures at either the medial or the lateral mal. A lot less common for them to actually be tender at the navicular, right? But definitely can happen. You can have, associated avulsion fractures of the navicular, particularly with a medial sprain. Sorry, guys, I'm gonna unshare for 1 second. Sorry, 1 sec. Let me check something. Yeah. All right.
Just needs to be better.
No shit.
Okay, guys, sorry. Well, I'm having to fix something on the next slide. Apologize. What is, who can tell me, by the way, all right, because we're about to dive into some lower leg pathology. Who can tell me, this computer, there we go. Who can tell me, obviously, about shin splints? Who has experience with shin splints? What are they? Any runners that I know we have runners in the room. What are shin splints?
What?
Yeah, what are shin splints?
Yeah, they're, aren't they, just like micro fractures all up and down the shins?
So, okay, so shin splint, obviously, right, is going to be basically vague medial lower leg pain localized to the middle third of the tibia. Now, generally speaking, right, this can actually, when we talked about injury nomenclature, this can actually be due to inflammation of the periosteum, right, as well. So, oh, guys, hang on, someone's coming to my door. 1 second, my dog's about to lose. Oh my God, that's so loud.
It's Bennett, Charlie.
I don't know. What time does it start again?
7:30.
Does anybody need a ride?
It may not be there till 8.
Charlie.
Or does anyone want a
I
ride?
gotta go to
Me.
Should I whip?
But we want to ride back.
Because we play Sunday.
Or I might.
Hey guys, my dog is ridiculously loud. That was probably painful. Oh my gosh. All right, so obviously, okay, so shin splints, right? Now, so obviously, this can obviously just be due to periosteal inflammation, right? Within the lower leg itself. Okay. But, right, these have the problem is these have a tendency to progress. Okay. Who can tell me what the problem is with shin splints and why it's actually really important with that injury to keep an eye on people's symptoms? Why is that? Why could that be an issue?
It can cause stress fractures.
Absolutely. Okay, absolutely. Okay. All right. So who remembers too, by the way, right? If you can tell me, whoops. Okay, who can tell me what's the main difference? Sorry guys, and I'll put the PowerPoint back up here in just 1 second. What's the main difference between obviously a gross fracture, right? And just basically a stress fracture. What's the difference clinically? What are people going to tell us?
So the onset of symptoms was different. So
Right.
wouldn't stress be slow and then, what do we call it? What's the other one? The other one like happened immediately.
Right. Absolutely. So with stress fractures, it's definitely going to be more gradual. Okay. Now my dog is like gagging and like basically puking on the floor. I don't really know what he's pulling on right now. Okay. All right. So obviously, let me reshare here. Better. Okay, so medial tibial stress syndrome, right? So clearly, okay, medial third of the tibia, this is pretty characteristic, right? So often we see this, right, in distance runners and sprinters, right? Endurance athletes specifically, basketball players, right, and other position players in football, right? And so usually we see this with periosteal inflammation. So the covering around the bone starts to become inflamed. And then ultimately, as Izzy so aptly pointed out, right, if left unmanaged, these can actually progress to stress fractures. So now you guys brought up several good points. What's the biggest difference though in the symptomatology here with shin splints? Is this typically going to be more diffuse pain, or is it going to be focal? Do you guys know what I say when I mean like diffuse versus focal?
Covers more of an area when it's diffused.
Right, so diffuse definitely covers more of an area, right? So it's going to cover more of an area over the tibia, as opposed to, right, a focal pain, which is going to be basically localized to one spot. They're going to say it hurts right here in this spot, right? And that's one of the main differentiators, along with history, that we're going to see obviously in stress fractures, right? So clearly, if you look at this picture on the right-hand side, okay, when we deal with stress fracture, who remembers, because we talked about this some in injury nomenclature, okay, who remembers if you see this, if someone's presenting with a stress fracture and you see this on a radiograph, right, what does this mean? Who can tell me what this means? You remember?
Isn't there a fracture because of that black line?
Yeah, it's the dreaded black line. Okay, now remember, guys, we talked about the fact that stress fractures, generally speaking, are not visible on X-ray. They should not be, right? Usually, in order to discern stress fractures, a true stress fracture, we need an MRI, right? Because these should not show up on X-ray. But if somebody presenting with a stress fracture comes in with symptoms and this does show up on an X-ray, like this, what this means is that ultimately they're going to have their tibia rotted. That they'll have to have a rod put into the tibia. What's the risk here? Let's say someone has a stress fracture that's progressed to this level or this stage, and they keep running on it, keep pounding on this thing. What could happen? What do you think? So this fracture could actually complete, right? So they could actually go from having basically this non-displaced fracture to the tibia actually breaking and displacing, right? Does that make sense? So if they were to continue to obviously pound on this, run on this, and put an axial load through the bone, this black line would obviously continue to widen. The fracture, as you can tell, would continue to, that line would continue to expand. They would break through the cortex, and they would have basically a displaced tibial fracture. Does that make sense?
Yes.
Okay, cool. All right, let me zoom back out on this thing. All right, so I'm going to kind of switch gears here for a second. All right, we're going to talk about a couple different lower leg pathologies. Who remembers, all right, who remembers, by the way, if I'm doing, right, a neurovascular exam of the lower leg, what pulses do I need to check?
Dorsal field and posterior.
Posterior tibial. Okay. All right. So what about neurologically? What are the different places where I need to actually test neurological function?
Like just test sensation on all sides of the foot.
Right. Is it equal? Is it symmetric? Right. So who remembers, by the way, and if you guys remember when we were checking, and this is something that we kind of flew by, but here's my question for you. Okay. You guys remember when we were doing our neurovascular exam, we looked at the spaces between the toes. We looked at that first web space. What nerve was I checking there? Who remembers that?
Start with a P.
Yeah, it does. It's one of them. So it starts with a P, and there's two different branches, right? I love where you're going, Bennett. You're thinking. I love it. Okay, so we have two branches. We have one that's superficial, okay? One that's a little bit, that's not so much superficial. So you're right, Bennett. Just throw it out there. What?
Perineal.
Absolutely. Which branch lives in that first web space?
Will had it right. He didn't say what he said earlier.
Okay, so it's the deep perineal nerve, right? Remember, that lives right in that first web space. So when you go down and you're kind of checking sensation in that first web space, okay, that's all deep perineal nerve. All right. So here's the deal. There is a pathology out there, and what we'll do for Monday is we'll finish up lower leg stuff. So obviously, because of our HLC site visit, we're not going to meet on Monday together because I'll be in meetings during that time. But I'll put a plan together for you guys as well. And sorry to kind of depart here from what we're doing for a second, but because of this meeting, I will actually be back in town in St. Peter late afternoon Sunday. If you guys are interested and or want to do a little bit of review over what we've covered so far, just let me know via email, and I'm happy to set some time aside with you guys on Sunday to just go over some review if you want. Okay. Anyway, so we have this pathology, right, known as acute compartment syndrome. Okay, this is typically caused by a direct blow to the lower leg. All right, so ultimately, what happens is after this direct blow to the lower leg, we typically have rapid, basically, swelling and hemorrhaging. Okay, and ultimately, what will happen is this rapid increase in intercompartmental pressure, okay, will actually cause neurological and vascular function in the lower leg to essentially be compromised. All right. So if someone actually obviously has, you know, acute compartment syndrome, and I'll show you guys a clip here in a second. What are we going to likely notice if they've got impaired neurovascular function? Okay, they'll have altered sensation at the deep peroneal nerve. Okay, weakness at the foot, right? And possibly diminished dorsalis pedis pulses. Okay, so acute compartment syndrome, particularly with neurovascular changes, guys, it's a medical emergency. They need to be referred. If you detect changes in neurovascular status with compartment syndrome, they've got to be seen in the ED quick, right? Because they may need an emergency fasciotomy. Okay, so anytime that you have someone that you think maybe just even has a contusion to the lower leg, make sure that you are doing a thorough neurovascular exam of the lower leg, right? To rule out any neurovascular changes, right? Let me show, I'll show you guys a picture. Give me just 1 second. Okay, stop share. All right. Alrighty. So here's the crazy thing, okay? Here's the crazy thing. Let me share this with you guys. Compartment syndrome, okay, believe it or not, okay, so compartment syndrome, right, as you guys can see, right, this can actually happen at any muscular compartment in the body. Okay, so this occurs obviously due to a blow to the lower leg. And as you can see, the muscles in the lower leg are divided into compartments. Okay, we have anterior, the anterior compartment, okay, lateral. Okay, by the way, what muscles do you think make up that lateral compartment?
Erroneous?
Bingo, peroneal muscles. Yep. We have the fibula here laterally. Okay, you can see it in this cross section. We have the tibia here on the medial side. Okay, so we have the lateral, deep posterior, and superficial posterior compartments. Okay, here's the thing. The anatomy of this compartment creates a really big anatomical problem, particularly, okay, with regard to the collection of fluid inside of this space. What's the first thing that you notice about the spacing between the compartments? Is there really space between the compartments?
No.
There's not. Okay, so here's the problem. Okay, as fluid begins to accumulate, there is no place for this for the fluid to actually go. All right, and so let's go to this next picture here. So you can see, obviously, here we have these compartments actually kind of highlighted for us here, right? Now, you notice though that within these compartments, okay, we have actually right next to these compartments the peroneal nerves. So check this out though. Okay, in the anterior compartment, actually, where the compartment syndrome actually presents the most, actually, the nerve that lives right at the back side of that compartment is the deep peroneal nerve. Okay, can you guys hear me okay? Is my sound acting up?
There you go.
Okay, so, and by the way, if this is not clear, let me know and I will explain this. Okay, but so right at the back side of this anterior compartment, we have the deep peroneal nerve. Okay, now, what do you think will happen? Okay, if I've got fluid accumulating inside of that anterior compartment after getting kicked in the leg, or maybe I had, you know, a crush injury, maybe something like a 45-pound plate, slipped off the bar in the weight room and fell on my leg, right? Something like that, right? And I got fluid building up inside of that compartment. As that fluid continues to build up inside of the compartment, how do you think my deep perineal nerve is going to respond? Will it be able to send messages to the foot and toes more efficiently, or really not really at all?
Not at all.
Okay, which means we're going to have sensory disturbances and we're going to have motor disturbances, correct? In the lower leg. Okay, check it out though. This is bananas. So this is, and there's also a chronic form of compartment syndrome that we'll talk about as well, probably Monday at this point. But there is actually, you actually have the ability to test the pressures, right, in the lower leg, right, and to essentially kind of see, you know, kind of whether or not these pressures are elevated, right? And so generally speaking, all right, as this fluid, and you can see what happens here, continues to build, you can see how the skin and fascia around the muscle actually starts to expand because of that accumulation, okay, of edema and swelling. You're going to see changes to the surrounding skin and fascia. Let me pull up another picture here and I'll show you exactly what that looks like. Stop share. Sorry guys, I know I'm jumping around. Okay, cool. That's weird. There we go, it's better. All right. There it is. Cool. Check this out. Okay, here's what I want you to notice about this. All right. Look at this picture. Okay, here's the issue with compartment syndrome. This is a gentleman that obviously suffered a blow to the lower extremity, and you can see. Look at up here on the right side, the skin tension on the right compared to the left. What do you notice about that right side? What does it look like comparatively? It looks like it's full, like crazy full, right? Like there's just a ton of fluid in there. Look at the skin. Look at the quality and color of the skin. What else do you see? It's shiny. Heck yeah. So the skin is obviously very shiny. That's because the increasing tension inside of the compartment causes the skin to almost kind of stretch out and become thin, right? When that happens, believe it or not, the skin actually becomes a bit more translucent, and light tends to bounce off of it a little bit more, right? And so we see that shiny, tight skin on the right leg compared to the left, right? Now, what else do you notice though about this guy's? Look, I mean, this guy's got really, really bad compartment syndrome. Look at his knee and his thigh, okay? Because this has nowhere to go. He's got a large knee effusion, right? And also the fluid is actually starting to extend into the distal thigh and quadricep. Okay, so obviously this guy's in the operating room. If they don't do something about this, he's going to lose his leg, right? So ultimately, let me show you guys how they handle this surgically. Okay, let me just okay, well, that's the pressure, so we'll talk about that. Okay, fasciotomy, friends. You guys see that? Okay, so generally speaking, right, operative treatment, emergent operative treatment for acute compartment syndrome like this is a fasciotomy. It's what they're doing here is they're making incisions into the lower leg and releasing the compartmental pressure, right? There is no other way to release that pressure and salvage those neurovascular structures other than doing a fasciotomy and opening up the leg and draining the fluid. Okay. Does that make sense?
Yeah.
How crazy is that, by the way? Right? Have you guys ever seen this or known
No.
anybody with this?
Literally.
Do what?
I said it looks like he just got to the ER, not that they just got him out of surgery.
Right. Well, this is actually a different patient, but what I wanted to show you is essentially how this is handled operatively, right? So, okay, and here's another kind of another image. So when you look at this MRI, okay, you can actually see some fluid accumulating inside of the compartments, but because there's nowhere to go, you see how the skin and fascia around the muscle is just like lit up bright white. This is what an MRI looks like of someone with compartment syndrome. It's just lit up bright white, full of fluid. Okay, so fluid on an MRI turns white, lights up like almost kind of like a Christmas tree. Okay, and so you can kind of see this here, right? Nice, it's really bright and kind of white. So that's fluid right there. Okay. So, and what they're actually showing you here is actually a pressure within the compartments, actually both pre and post surgery, and we'll actually talk more about those pressures specifically, right? So there again, another imaging finding, right? This is actually the posterior compartment here. You can see fluid actually accumulating, obviously back here as well. Okay, so we'll talk about the chronic form of this next week. It's essentially time, I think. Yeah, but so guys, like I said, I will get in touch with you this afternoon and give you guys a plan for Monday. Like I said, we're not going to meet on Monday in person, but we're basically nearly done with the ankle and lower leg, and we're going to start the knee pretty much, I think, right before spring break. So we're about to knock this out and finish it up. Any questions, guys? And hopefully, by the way, my plan as well, I'm going to get a ton of grading done over spring break. So you guys are going to see some grades coming through as well for everything. And hopefully I'll even be able to get to it before then. But you guys need anything at all? Are we good?
Good.
We're good.
All right, guys. Thank you so much. All right.
Bye, Wade.
Bye. And if you guys are interested, if you want to get together Sunday, just send me an email. All right, because I'll be in town. Okay. Bye,
Sounds
guys.
good.
All right.
Bye, Wade.
See ya.